And moving quickly to the next oration, we have the next oration name after the Srimati Santosh Devi Gera oration. I want to introduce her. Srimati Santosh Gera was born on 18th May 1923 at Minawali in the present day in Pakistan. In India as a refugee during the partition with empty pockets. She lost her husband at a very young age of 33 and took over the role of a caregiver to her three sons and one daughter. The resilience and will that she possessed and displayed are a testimony to the legacy she has left behind. Two of her sons are doctors in Delhi and UK, and one of her grandchildren is our own beloved Dr. Kamaldeep Chawla, sir. Srimati Santosh Gera left to heavenly abode on 17 January 2014. And I would like to invite Professor Dr. Kamlakar Tripathi sir over the stage for delivering his oration lecture. Sir, please. And I would like to invite all the chairpersons on the stage to felicitate us, sir. Sir, can you please have a seat with us? And two of yeah, two of our family members of Srimati Santosh Devi Gera is present with us. Actually, three. Dr. Prakash Gera, sir. He is sitting over there. And Dr. Kanta Chawla, ma'am. Srimati Kanta Chawla, ma'am. She is present over there. So I would request our chairperson Mona madam, Kamaldeep sir and Akash sir, if because of difficulty of climbing the stairs, I request both of them to please present them.
We will be coming there only to present because of family issues.
So please be chair. A big round of applause for Dr. Prakash Gera sir and Srimati Kanta Chawla ma'am. And her grandson, Dr. Kamaldeep Chawla sir is here. He is a national convener of the IDCM, a national body, and the Metacon 2024. So I would request all the chairpersons to please come on the stage again so that we can proceed further with the oration lecture. I request the chairperson to felicitate our orator, Dr. Kamlakar Tripathi sir, with the medal and present him the shawl and the turban, and followed by the conch. Vasan sir, please join with us on the stage. I would like to introduce Dr. Kamlakar Tripathi, sir. Dr. Kamlakar Tripathi is a BSc, MBBS, MD, General Medicine, DM Nephrology, MNAMS Nephrology, and many more degrees in his credit. He is a recipient of prestigious Padma Shri Award, the fourth highest civilian award given by the Government of India, Honorable President of India. Dr. Tripathi has officiated as a professor and head of the Department of Medicine and also the Department of Nephrology, Institute of Medical Sciences, Banaras Hindu University, Varanasi. Dr. Tripathi has over 40 years of rich experience in the various fields of medicine, including the medical practice, teaching, research, and more. And his commitment and dedication to the medical education and the patient care has earned him a revered position in the medical community. He is a recipient of Guinness Book of World Record citation in 2013 for enrolling a maximum number of diabetic patients on a single day at one site in the study in the collaboration with the Novo Nordisk. He has over more than 300 original publications in both the international and national journals, and he has contributed to various books and the chapters. Dr. Tripathi has received many international and national awards in the nephrology and the diabetic research. He has also conducted the numerous special workshops and the training in the medical education across India. His interest is nephrology and the diabetes. He is a life member of various international and national scientific bodies. It is our utmost honor to present you with the Srimati Santosh Devi Gera oration for the year 2024, sir. So I request you, sir, to kindly proceed with your oration lectures.
I feel humble, honored, and so little and so much by my immediate senior, Dr. P.C. Gera. Dr. Gera was immediate my senior, and Dr. Parikh knows the tradition of medical education and teaching in this country. He's such a respectable person, the former API president, Dr. Shailesh, and many more, Dr. Bhavaratni. Dr. Verma, who delivered oration before, such a wonderful basic science worker. But I come from a different tradition of medical teaching. In Sanskrit literature, it is said that once you have to learn something, the student has to be very close to his teacher. That is called upavishat. And that's how the upadhyaya word has been coined. I come from Kashi. Dr. Gera was my senior. When my mother died, he was my physician, treating physician at that time, my mother's physician. And I have still death certificate of my mother with his signature, and I'm grateful. These people are real our teacher. In medical education, if you process the competence of the person, it's 6 months junior, 6 months senior. He knows better than your wife, better than your father, better than your mother, better. He knows every good and bad things out of you. The tradition of medical teaching at that time was people like Dr. Gera would catch hold of your hand, teach you how to palpate a spleen, how to move a stethoscope inch by inch from A2 area to P2 area, from the sternum, how many centimeter, the changing nature of second heart sound, the first heart sound, the muffling up sound, and the rapid inflow phase of the cardiac cycle. That meticulous teaching cannot be replaced. So I salute Dr. P.C. Gera for remembering me, and I'm really obliged, and I don't have words. I was not aware of it. Even Dr. Akash, when we met, and Dr. Akash asked me to come for, I thought I'm coming for a lecture, not for oration. So I'm sorry if I do not have the content what Professor Verma had before, the scientific content. Kashi has a different tradition. Maranam mangalam yatra vibhutischa vibhushanam. Death is celebrated in Banaras. No other part of the world. Death is mourned everywhere. In Urdu, you offer Marcia, you offer Noha, sonnets. It's only the Kashi where death is celebrated. Vibhutischa Vibhushanam, the ash of the Lord Shankar is your ornament. Kaupinam etavastram, the only loin cloth. Sa Kashi kasyana sevyate. Why should you not? Why should you? And you should be living in Kashi. The medical teaching started from Kashi, 10,000 BC. We have carbon dating of the Royal Asian Society published this article. And the ghats and the stones which have been built up belong to 10,000 BC period. That's old. And the Lord Shankar, when took the birth as King Devodas, in incarnation of Dhanvantari, he started teaching medicine, practiced medicine. Shushruta did the first dissection, authentic dissection, lived in Varanasi, taught in Varanasi. And now today we are honored to have our Prime Minister from this very province who changed everything of Benares, Mr. Narendra Modi. I have been asked and given the task to, as Dr. Verma said, normally orator decides his topic. He had a privilege. My topic was decided by Akash. And Akash is the sky is the limit. So he gave me a topic which is like the real internal medicine, what we learned at our undergraduate level. And he asked me to cover the comorbid condition. Most of the part has been covered in the lecture somewhere in the morning. I was listening, so I'll quickly go through. And because the 78% of the people are suffering or would be suffering, and prevalence is so very high in middle and low income group, which group matters for the economy of the country. Because diabetes is a forerunner of insulin resistance, and insulin resistance could be either in the form of hypertension or in the diabetes or metabolic syndrome, and it starts 8 to 10 years before the clinical manifestations of dysglycemia or the hypertension. Can involve the heart, macrovascular much earlier, could be the first and the last event in the history of the person. The micro, which starts about 10 years before, and can lead to the comorbid condition. So every 2 out of 3 hypertensive patient is not alone. It's two internal medicine. The subject which all are missing, gradually losing hold over them because of every internist want to become super specialist. But there's a problem in the treating such patient because, and the incidence of these comorbid conditions could be anything from 60% like obesity, even in this hall, by definition. Only Dr. Shailesh Trivedi is not. Many of us would be in the form of obesity or metabolic syndrome. We have impaired fasting glucose. We have dyslipidemia and others. The chronic comorbid condition, which may not be associated with something like close to 48% with diabetes, obesity, followed by the cardiac disorder. They could be independent, they could be dependent, they are affected by the treatment, they are affected by the investigative procedures. There are many conditions which could coexist and probably patient may not be aware of it. These are the identifiable conditions, like sleep apnea. You give a good BiPAP, obesity disappears, hypertension disappears, diabetes disappears. So sleep apnea, that could be drug-induced causes, that could be my specialty, chronic kidney disease, renovascular. I'll talk few words for these. But what's important is that type 2 diabetes association in hypertension. And there is a strong predictor of diastolic blood pressure to the cardiovascular disease, diabetic nephropathy. Therefore, diabetologists and endocrinologists and nephrologists make it a point to control blood pressure very strongly. 65% of diabetic patient have a isolated systolic hypertension. Systolic hypertension is very difficult to control in elderly population, especially in the presence of chronic kidney disease. I was talking this part, how does insulin resistance is a forerunner. In any way, it could manifest as the obesity, it can manifest as the hypertension, it can manifest as the diabetes, is because of the sympathetic nervous system and RAS activation, inflammation, and then also leading to the vascular stiffness during the remodeling. It starts about 8 to 10 years before. And we wrote a book together with Dr. Narsingh Verma, and where we demonstrated that the vascular remodeling before clinical appearance of the hypertension, it starts 5 to 10 years before. And the wall, the intima, the endothelial bed, they all starts remodeling. And they do not let you feel that you are hypertensive. So they keep on changing the shape. But in due course of time, it is this part which is manifested as a comorbid condition. So the insulin through MR activation and with the consistent hyperinsulinemia is responsible for arterial stiffness. And the story starts from here. You may not be diabetic, but still you have insulin resistance because of your arterial stiffness and change into the RS system. This is the definition, and this we all know, so I would not waste much time on it. But this is important, the goal, 130 by 80. And all studies and all landmark studies, HOT, APCD, UVBDS, IDNT, ADA, all have said JNC7, the goal should be less than 130 by 80. Can we move little lower? Answer is no. Like we had with nifedipine, the J-shaped curve, if you try to reduce systolic blood pressure aggressively in elderly population, there are chances they might deteriorate. So they increase the hazard ratio. It affects CV mortality, and significant affects CV mortality, close to about 51%. The CV event would be controlled, and the CV death up to the 67%. What a gain. If we can reduce cardiac death by 67% only by meticulous control of blood pressure, we have won half of the game. The heart failure is further important issue because most of the time the breathlessness is taken as a part of our increasing age and the lung compliance. But this is the early sign. Thanks to good echo studies, now we are able to identify. But then it certainly adds to, if you control the blood pressure, the micro and macrovascular complication both would be taken care of. We have the huge landmark trials studies available in treatment of hypertension, diabetes, and kidney disease. In everywhere, if you look number of the blood pressure medicines, that could be 1, 2, 3, 4. Welcome Dr. N.K. Singh, one of the very important person for CME and roping us together. So all, don't criticize your colleague. This is a bad habit. A super specialist, when gets a prescription of internist, passes some remark, that's a bad remark. You cannot control blood pressure with 1 or 2 drugs. You may require 3, 4. We nephrologists use sometimes 5 to 6 drugs to control. Still blood pressure doesn't, because of the entire definite mechanism. We'll talk in a moment why it is so. So I'll come directly to my specialty, chronic kidney disease. Initially, we all have a glomerulonephritis, unknown condition. Now we understand there are many more. We have interstitial, we have a pyelonephritis, calcinosis, neoplasm, and analgesic nephropathy. This is the concept, how many nephrons you are born with. Barry M. Brenner, the president and the famous book wrote on the nephrology, he had a concept that if you are born with less number of nephron, like less number of beta cell, then you cannot tolerate the onslaught, and that leads to resetting of the whole process. That could be accelerated sclerosis of the remaining nephron, They double up, you ablate the kidney, the remaining half kidney would take the job. You remove one kidney, the single kidney would take the job up to 100 to 300%. And these rest number of nephrons is related to initiation of diabetes, hypertension, toxin exposure, complex deposition, and they would activate vasoactive system. So this is in a nutshell the flow in diabetic kidney disease. Looking at the proteinuria, no proteinuria. If you have proteinuria, this is probably you are dealing with chronic glomerulonephritis sitting in, and then you require ACE inhibitor or ARB, and you can add on 4 or 5 medicine together if it is associated with, without proteinuria, the tubulointestinal disease. Again, this is affected by the age, race, comorbid condition, and then you require to another 4 to 5 medicine. These are the newer drugs. They were diabetologists with first. They came for diabetology to take care of the blood sugar. Cardiologists have snatched away. They said, this is my drug. You don't require to use it. But empagliflozin in both dapagliflozin in presence of chronic kidney disease, they help in reduction of the blood pressure also. What are the compelling indications where you use when you have a heart failure? You have 4 drugs, diuretic, BB, ACE inhibitors, and ARVs. Post-myocardial infarction, you have only beta blocker and ACE, and these are the landmarks trial. Secondary hypertension, somebody talked it meticulously, but as I said, our teacher would teach us where to put his stethoscope to appreciate renal buoy in renal artery stenosis. Even after DM, it becomes very difficult, and half the patient by PGI and dear Professor Chub, my teacher, would ask them not to appear in the exam. Place at the flanks, near the renal angle, you put over here. But this is common, and good cardiologists would put the catheter down after doing angiography, also look at the perfusion of both kidney and would pick up it. 19% of CAD patients have association. In 31% over 3 years have under intervention studies. Women or more, fibromuscular dysplasia, there could be traumatic injury. And these are the good color Doppler, good radiologists, they know how to do it. We have published a lot of papers on it. 95% sensitivity. CT angiography is very easy to do now. And you can pick up 90% sensitivity, specificity. When you add angiography to it, 97% to 95%. So that's the advantage of the technology. But what's more important for the internist to take a decision whether surgeon should operate or shouldn't operate? And it is because of the hemodynamic stability. Severe is the stenosis, this is significant, and if it is less, then it is not significant. And with the peak systolic pressure gradient, you can decide whether it should be operated, shouldn't be operated. So therefore, the core treatment strategy would be either to ACE, ARB, or CCV diuretic, or then you have diuretic with all the 3, and then you have a resistant hypertension. Beta blockers still have come back, especially the non-selective one, and they are the part of the treatment prescription. Not my specialty, but internists always feel it. Everywhere, district hospital, primary care physician, even in the Department of General Medicine, stroke would be primary taken care by the internal medicine. And therefore, the presentation of the hypertension, when you look in relation to this drop in the systolic blood pressure, this is single stroke mortality would be in the younger people 60%. Look at the figure, 64%. In elderly people, this is 33%. So treat meticulously these patients, and we know the history of Roosevelt, Frank Roosevelt, whose 220 blood pressure was taken as the normal at the time of his death. The diastolic blood pressure is equally important, but less than the systolic blood pressure. And when you look at the stroke death according to the both Mr. Fit trial, and there's a very high incidence the moment it crosses 151 by 98. This is important because in emergency, all our younger colleagues would be facing this crisis. Severe rise of blood pressure, initial 48 hours. Should it be lowered or shouldn't be? One should target of less than 180 ischemic stroke and 120 by the subarachnoid hemorrhage. So the recommendation is target BP in ischemic stroke at least 24 to 48 hours at the time of event. And if the patient is on thrombolytic, then 185 by 110. With intracranial hemorrhage, 160 by 100. And subarachnoid, 140 by 90. This is important now because if you have an interventional radiologist available and you can do DSA within 3 to 4 hours, then probably you can take a decision whether to do a thrombolysis or to intervene or to put a stent even over there. Otherwise, this is important in acute infarct, less than 5-hour duration. Initially it was 3 hours, then 4.5 hours, now less than 5-hour duration to understand it. So this is the older drugs like nicardipine, clavidipine. Labetalol is the drug of choice if the patient is not on hemolysis. Cardiologist, all old-timer fashion teacher at that time when the DM was not, everybody would love to become a cardiologist. But now we have wonderful drugs which look at the preserved ejection fraction and reduced ejection fraction. And now these are the 4 pillars everybody would like to add: ARNI, beta blocker, lipid lowering, SGLT2 inhibitor. These are the therapeutic targets for ARNI because this MRAs, because they also have action on the fibrosis, the fibroblast growth factor, and reduce also the atrial fibrillation. This is a difficult question, isolated systolic hypertension. We have only one drug, is still calcium channel blocker, in spite of all the limitation. Pedal edema, tachycardia, resting tachycardia, no drug can compare it. And that is the only issue. So systolic hypertension with Framingham study have shown that the blood pressure should be close to 160 by below 195 millimeter mercury. Endocrine causes, and we all know this about the family history, the meticulous work, refractory hypertension, hypokalemia. FIOs have been still there, and because of the better imaging techniques, we are able to pick them much early. We have one of our young students who become professor, assistant professor, very young age, as they're difficult to control blood sugar, has hypertension, realized that it was a pheochromocytoma, and the person ultimately succumbed. So you do get still some of the cases of FIOs. You can do MB scintigraphy, you can do CT scan, and DOPA PET, and you can pick up. And the management depending upon the technique, surgery is the drug of choice, otherwise you can use beta blocker. Coarctation already have been answered. This part was not talked much, like we have a pregnancy in diabetes, a pregnancy in hypertension. And if you look the criteria from chronic hypertension to gestational hypertension to preeclampsia, consistently 140 by 90, 140 by 90, 140 by 90. Whether it is American College of Gynecologists, whether it is the International Society Working Group, all were consistently the range from 140 by 90 before 20 weeks. And if they cross, it becomes important. The reason is we have very limited drugs. We do not, still alpha-methyl dopa may not be available in most of the clinics. So all private practitioner internists, whatever level of the knowledge they have, they use still that nifedipine and prick it, put under the tongue, quickly drop off the blood pressure, sometimes leads to catastrophe. Therefore, we have to know hydralazine. One can start in acute management. Labetalol, luckily, is available around. It's injectable. Nifedipine can be used with cautious. Nitroprusside has to be prepared in the hospital. So the drug of choice in the chronic group is methyl dopa, beta blockers, labetalol 300 mg, clonidine, short acting can be used, central blocking. Calcium channel blocker for the limited birth of the baby. Diuretics are not indicated. ACE inhibitors, ARB, totally contraindicated, and therefore they need to know it. This is labetalol 2 times daily. The dose requirement is very high. Nifedipine can be used up to 120 milligram. Methyl dopa is available, one of the best drugs. This is her new lab formula. You can use hydrazine, nifedipine, methyl dopa. Thyroid role, we all tend to forget that another comorbid condition. You can have both. Hypothyroid can present with hypertension, hyperthyroid can present with the hypertension. And we need to follow them. These are the symptoms of hyperparathyroidism. PTH is supposed to be in one of the mechanism of pregnancy-induced hypertension is because of the high PTH activity, increased calcium turnover. And that could be the cause like palpitation, forgetfulness, kidney stone, insomnia, tiredness, excessive urination. So the high PTH turnover is cause for calcium deposition and then vascular smooth muscle contraction, collagen deposition, and leading to the hypertension. This is the study available where have shown this is the drug which is used, ETAL, which is a significant drug to take care of the primary hyperthyroidism, and when you use this drug over the time can reduce the blood pressure. Cushing syndrome, as I said, could be ACTH dependent. This is diagnosed clinically, but we also have now methods to do it. You can localize the tumor, and these are the different methods available for the treatment from transfemoral surgery to the drug. Obesity could be the mother of many more diseases together, and this could lead to lipid abnormality, dyslipidemia, renal failure, stroke. These are the drugs which are available, FDA approved, off-label use. We have societies, continuous societies taking CMEs for 2 to 3 days. We have metformin, semaglutide is one which has now come off-label use, canagliflozin, paramylidine, all this is being used off-label. And then we have the drugs like topiramate, buprenorphine, all these are being used off-label, but FDA-approved drugs are still, liraglutide and semaglutide are there in our list. Of course, lipid-lowering drugs. And we have now monoclonal antibodies, very costly. There could be inclisiran, when there could be vampiric acid, and this dyslipidemia could coexist with hypertension, and all they need to be answered. What are the drugs which can cause hypertension? And how many times we screen in resident hypertension like immunosuppressive drugs, non-steroidal anti-inflammatory, COX-2 inhibitors, estrogens, weight loss agents, stimulants, mineralocorticoids, anti-Parkinson's drugs, monoamine oxidase inhibitor, anabolic hormone. And this is one of the issue in now IVF, use lot of hormone. So we create a lot of diseases also. We create premature hypertension, we create obesity, we also create diabetes, and becomes point of the interest. So this is the last summary slide. The hypertension as a comorbid condition could exist independent of the risk factor, could be part of chronic pulmonary disease, chronic kidney disease, type 2 diabetes, obesity. We now have started identifying this condition because of the good echo, atherosclerotic cardiovascular disease, ASCVD, and these are the patients where we need to answer. There could be atrial fibrillation, that could be cognitive dysfunction, stroke, in chronic heart failure. These conditions could be independent, could be dependent. They need a good internist. They do not need super specialist in compartment. More super specialists come to visit, that it make more problem for the patient. They lead to a lot of iatrogenic phenomena. Patient is fed up. So this is the duty of all primary care physician, medical teachers association to be aware of that we should develop internal medicine more precisely. And then thank you very much. I do not consider myself fit for oration because I'm not a basic research worker like Professor Verma. We have been primary school medical teacher of teaching only percussion, palpation, auscultation. Somehow we have survived and made our presence. So thanks again to Dr. Gera on the name of his mother, my mother, equivalent to my mother, taking care of my mother. It's my good honor that I have been able to give oration on the name of his mother. Professor Dr. Gera, thank you very much again, your family and the family members of Dr. Chawla, and thanks to each of you.